Hi, Vanessa.
Hi, Cara.
This conversation with Loretta Duggan is so joyful. I mean, beautiful and very science-based, but so joyful because Loretta, who is from rural Georgia and practices adolescent health, adolescent medicine in Georgia, brings this combination of knowledge, scientific knowledge, and love and respect for the body with a very clear understanding of the things that get in the way of care. So she, grew up in a rural community and she faced all of the issues about access to care that so many people face. And if you haven't faced them, you've undoubtedly read about them, where you can't get to a hospital. If you can get to a hospital, the hospitals are underserved. There aren't enough people in the hospital. Just ambulance systems in the rural areas where sort of getting access to a care provider in the field is so hard. All of these things informed her way before she went to medical school. And then, Vanessa.
And then she went to medical school and was studying family medicine in South Carolina, and then did her fellowship training in adolescent medicine in Miami. And I talk about that level of her training because, as she will share, there are things she learned about her own experience, her own menstrual health, that she did not learn until she was a resident in medical school. That is years and years of schooling on top of everyone else's regular schooling.
And she's not the outlier.
And she's not the outlier. It points to how much people don't know, how little it's discussed, how little it's studied. And so the combination in our conversation with Loretta is one of personal experience, deep professional experience, and she has a love of teenagers and young people, which we share. And one thing she does in a really powerful way is starts to model what her conversations with her patients sound like and how she gets connected and builds trust with her patients. And it's something that we as parents struggle with. It's something that physicians struggle with. And I think she's really a wonderful paradigm for how we can all find ways to connect with kids and young people so that they can take care of themselves and keep themselves healthy and safe. Hi, Loretta.
Hello, ladies. How are you all doing?
Happy to see your smiling face. Thank you for joining us.
Yes, thank y'all for having me. I'm so excited. So excited about our conversation today.
Our listeners might be unused to hearing such a beautiful Southern accent on This Is So Awkward podcast because it's not often that we have such a beautiful, lilting, calming voice on the podcast. Normally it's me and Cara.
My voice accepted. Is that where this is going?
And not only that, Loretta, but I actually listen when I'm reviewing podcasts, I listen to them on like 2x. And so we sound particularly manic and bananas. So I'll be excited. And my laugh is like really out of a cartoon. So I'll be excited to hear how yours sound. But can you share with our listeners where you're from, what you do, what makes you such a unicorn in the world? And my words, not yours. And just like help them get to know you a little bit.
Absolutely. So again, thank you all for having me. And hello, everyone. My name is Dr. Loretta Duggan. I am trained in family and adolescent medicine. And I'm also the CEO of Her Health located in Athens, Georgia. And so I'm born and raised rural Georgia, college in Georgia before going to South Carolina to finish family medicine. And that's where I actually learned about adolescent medicine. Up until that point, you all, I was like, hey, we're just chilling. We'll figure things out. But everything kind of changed. It changed when I turned 7. That's when I lost my grandma to a massive heart attack. So all the things you think of in terms of rural medicine, lack of access, lack of care, lack of having a hospital, we were up against all those things, right? So that took me down a preventative track, and it took me so far, in my medical journey. And even now, prevention is still huge. But what I had to realize, you all, was the importance of my story. What was my story? Yeah, I struggled so bad with my periods. They were so, so painful. And it took me becoming a whole doctor, almost out the door, before I realized that my condition had a diagnosis. It had a name, and it could be treated, and my life could be so much better. I didn't have to be double over in pain once or twice a month in dealing with my periods. And so if I didn't know, I knew that there were many others that needed to know as well. So really embracing my story. And I love talking with my teenagers, just learning from them. And that's why I discovered the specialty of adolescent medicine. So I was like, oh yeah, we're doing this.
Did you have an aha moment in medical school or in your training that allowed you to name what was going on in your body? Like, what was that moment for you?
It was not until residency. I was on my women's health rotation.
Doctor already.
We already had the long white coat.
Okay.
We already had the full long white coat before we realized that, goodness, you've been like 2 decades. I was almost 30 then, dealing with my periods and learning that this could be different. My life didn't have to be that way. And I wanted to bring that to pretty much everyone else at that point. I was ready to preach the gospel at that point.
Let's just shine a really bright light on that. You went through high school, college, medical school.
All the way through.
All the way through. And there is so little awareness. And it's better now. We're going to talk about that and things that you're doing and other places that people can get information. But by and large, there's so much unawareness about what issues can be related to painful periods, that it took you until you were in your residency, seeing your own patients and caring for them yourself to have that aha moment. That's a very, very, very clear example of why so much of this goes unseen, because even doctors don't know.
Yes, it's a telling sign of just how much of a knowledge gap exists, you all, and why it's so important to talk about these things, to talk about period health and how it relates to overall, you being productive, you being able to go to class and study, do what you need to do in a regular day. All of those things are impacted by our periods, and there are ways that we can manage it better. And that's why I'm so excited to share, what it is that I do, because you don't have to suffer. You can know what's considered normal. And if you're kind of outside of those ranges or things aren't working the way you expect them to, it's okay to ask, because no one asked me about my periods and I wasn't volunteering information either. So I just figured out how to deal with it and how to manage. But it was a better way. And the other side is so much greater. It's so much more awesome being on this side of this.
Loretta, when you were in residency, when you're doing your training in adolescent medicine, what fields go into that training? And I want to think about how we help people understand what's so special about that specialty, pardon the repetition there.
Okay.
And what's really effective and sort of holistic and multidisciplinary about that specialty.
Yes, there's so much overlap, like with primary care when it comes to adolescents. So we can catch them at different phases. So whether it's the pediatricians caring for them earlier on, whether like myself, family medicine, we can cover the full gamut. Even internal medicine as well. They can catch them around 18 and up, depending on what they're comfortable seeing. So really, those 3 specialties, we can all subspecialize in adolescent medicine in one way or another if we choose to.
And do you do extra OBGYN training for adolescent medicine, or is that separate?
So it would depend on your program that you go to. Some may be heavier, like in the women's health department, in terms of like IUDs and Nexplanons, getting more comfortable with the gyne exam. I know for us, we did a lot of polycystic ovarian syndrome, PCOS, a lot of eating disorders as well. But also adolescent medicine folks can help with substance use if they're dealing with substance abuse, mental health challenges as well. So it's a wide range, but again, it kind of focuses on the teen, the tween, that transition into young adulthood with those specific topics and learning how to communicate best with them so you can get the information that you need in order to counsel them and provide them the information that can really help them to live their best, healthiest life.
And, just Vanessa, so that you have a sense of these 3 different feeders to adolescent medicine. The family practice doctors have spent their entire training working with the gamut of patients, right?
Yep.
But pediatricians, this, your kids go see a pediatrician and they're little chairs and little exam tables and everything
nice
is
colorful rooms and everything.
Happy, right? And it's really meant for the littles who are going to struggle. And
you mean when my 6'4" son, his legs are like draped and dragging on the floor of the exam table?
Yes. And then when you go the other side, adult internal medicine, while it should be used for all adults, and if there was an internist on this podcast right now, they would be like, waving their arms and jumping up and down saying, please, people, come in for primary care. Let us help you with preventive health. But by and large, those practices skew older. Like you're not talking about drinking and drugs and sex in an anticipatory way. You're talking about how drinking and drugs and sex have landed you in this office with this problem you've been dealing with for 40 years. So what makes adolescent medicine so special is that you do have these 3 different groups of people coming together with 3 really different perspectives, but they're all focused on one group. And you gravitate, Vanessa, towards adolescent medicine doctors. I find you in conversation with them. You like if we're at an event together, you're always hanging with the adolescent person. And it's because there's this special little quality to all of them, regardless of where they come from.
Because we love teenagers and we totally appreciate them. So today, Loretta, I know there's a lot of different stuff we could talk about, but we're going to look at menstrual health. And then we are going to spend some time talking about contraception and STIs, the really juicy stuff down the road. But you talked earlier about your own period and your own experience, and not realizing, there's actually, I don't have to live this way. There's something that could help me. And on top of that, as a Black woman, I didn't know that I was more likely to suffer from this condition or these experiences, right? And we had Dr. Karen Tang on the podcast about her book, It's Not Hysteria, and she goes into all of the data and the racial differences amongst women experiencing these different conditions. And this is really important to be aware of. And I'm sure in a minute you will talk to us about how you educate the people who come into your practice and give them really good information. But let's ground our listeners in how menstrual health is a vital sign and how we can look at menstrual health as a way of understanding overall health.
Yes. And I love to phrase it that way because we all know about the blood pressure check, right? We all know about getting our weight checked or having our heart rate looked at, all the things they do when the nurse triages you before you see me. But one thing that may not be asked about as frequently is, how are your periods? When was your last period? Because that can tell us so much about what's going on with your overall health and other conditions we may need to think about. So if it's been 2 months, 6 months, a year, since you had your period, okay, outside of the obvious, we're going to make sure you're not pregnant.
I was going to say.
But if it's that irregular and it's been at least a couple of years since your period started, okay, now we need to do further workup. Do we need to check certain hormonal levels, like looking for a PCOS type picture? Do we need to look at your prolactin level? What
does that look at? Yeah, tell me what prolactin does.
Yeah, so prolactin is responsible for helping to produce breast milk. So anyone that hasn't had a baby or anything, they shouldn't be making milk at all. But sometimes if that level is up, there may be some type of tumor or something that's present, and you can have increased levels of prolactin. Some people may even have headaches as well. Then we want to check that. We want to know, because that can throw off other things, overcome other hormones that are needed for us to have a regular period. Looking at our thyroid as well. The thyroid can mimic so many different things. Looking at their nutrition status. Are they getting enough calories or are they restricting? Are we dealing with someone that's doing excessive exercise? Now we may be dealing with disordered eating. So just from inquiring about how your periods are doing, then that can lead us, on the road of, okay, is further workup needed at this time or not? So that's why I love asking about it. It's kind of like an underlying thing. Right. But again, it's so important because of those.
And do you ask what their periods are like? Like, does it affect their daily life? Are they sleeping? How often are they changing pads or tampons or whatever? Like, do you get into that specificity?
Yep. I want to know duration. How long is it lasting? How heavy are you bleeding? If you're having to change every 1 to 2 hours, and it's not because you want to be clean. No, it's because my pad runneth over or my tampon is leaking. Those are the things I want to know, because if you're a heavier bleeder, we need to work that up. Are we dealing with a bleeding disorder? Or, if you're just a heavy bleeder, getting an ultrasound done. Those are things we get into all the nitty gritties of it. Pain, definitely, because if the over-the-counter things aren't working, that's a perfect time to have a conversation about, okay, what are your other options in those cases?
What I love about this is you're not asking them if they're having a normal period.
Right. What is their normal period, right? Because it can vary across the spectrum. You're exactly right, Cara.
Right. And you lived with discomfort for years, and maybe after a while you thought that was
It became my normal. It became
and you
my
needed
normal.
to become a doctor in order to figure out that normal wasn't normal.
I had to stay prepared and ready, because if she ever tried to show up early or a little bit later than what the calendar said, I could not do that on my own. We could not ad-lib having a period.
But that's such an important point, Loretta, because when we work with kids, what they worry about are the logistics. Like, they worry about, what do I do if? How do I handle it when? And you're now a fully grown adult, a physician, and yet you're remembering what it was like if you were caught out, that you had to be prepared. Can you talk about that for a second? Because I don't think caregivers always appreciate how much kids worry about the logistical stuff.
How stressful it was, right? If we're getting ready to take a trip somewhere or do spring break, I'm like, okay, where am I on the calendar? I got to make sure that I have X, Y, and Z lined up and readily available. Even when I played sports, while I was playing on the court or running, I was good. But as soon as that was done, the pain was right there, just as, if not more intense. And so in a way, I feared my period because I knew what that meant for me during that time of the month. And I don't want teens, tweens to fear their periods. I want them to understand them so that they can embrace it and know when it's time to seek help, and know that it's okay to reach out for what they need.
So let's talk about the ways people can manage and treat all the different things that we just mentioned. Very heavy bleeding, pain that gets in the way of managing your normal life. Maybe there's mood stuff. What are the walk us through the options.
Just to sort of narrow the question, because that's a big question. That's like a year's worth of training. That was a very good question, Vanessa, but it was very big. Like, if you've ruled out all the other things, their thyroid is fine, if you've looked at hormone levels, like you've got someone who is, you have not put them in the PCOS category. This is someone, we don't like the word normal, but everything's checking out, right? And now let's start there with some of the
I just want to understand first, though, how do you rule out PCOS?
Oh,
because
good.
we're now understanding how common it is, and that was the thing that you didn't know about. So how do you as a physician rule out PCOS or diagnose it?
Right. So thankfully they have criteria to help us with that. And 2 out of 3 are needed. And so first, there's going to be some type of ovulatory dysfunction. So essentially with that, we're not releasing an egg. We're not ovulating the way we normally would expect to. And so with that, that can lead to irregular periods. Sometimes they're amenorrheic, where it's no periods at all, even though they initially started their cycles. So that's usually one of the first things that we see. The second would be evidence of what's called hyperandrogenism. And with that, that's an increase in your testosterone levels, what we're going to usually see in our guys. And ladies, we make testosterone too, but just not at such high levels like our guys do. And so we can start to see issues with our acne. We can see evidence of hirsutism, where we're having hair that's growing everywhere, where it's hard to manage, even if we wax or laser, we're just having to do something all the time for it because it's so thick, because it's so prominent as well. So those are some of the things that you can see. And then thirdly, seeing on ultrasound, which you may or may not see, those changes in the ovary where you can see a lot of different follicles. And I think of follicles as like the baby eggs, the eggs that haven't matured yet to become an actual egg. They're still little babies, just kind of waiting to mature. But there's never one dominant egg that really matures. So the overall weight of the ovary can be a little bit heavier. And sometimes they can see what's called a string of pearls. So it's multiple follicles kind of hanging out there. If you see it on ultrasound, great. It can help you with the diagnosis. But if you don't see it, that doesn't mean it's not there. Again, we only need two out of the 3. So if the first 2 have already met, we're having our regular periods, we're showing signs of elevated hyperandrogenism, whether it's clinically or we can see it in the lab sometimes too, when we check their blood work. Those can pretty much set up a diagnosis for PCOS.
And how do you treat PCOS in the age group that you are working with? Because we've talked to Karen Tang about how you treat it in adult women who are maybe even past childbearing years or are older, but in the age group that you work with, which is 11 to 26-year-olds, how would you address the symptoms of PCOS?
Right. So with that, I would still base it on their goals of care. So of course, I want them to have regular periods for sure. I'm not going longer than, say, 3 to 4 months at a time because we don't want that buildup in the lining of the uterus. And then they may have a super heavy bleed or even risk of like endometrial cancer down the line because it's just unopposed estrogen that's building up there. So really, we want to try to help regulate those periods if they're okay with starting hormonal therapy. They may or may not be overweight, so you can't just automatically assume, but a lot of the times there's a change in their weight where it starts to go up, and then they're starting to see other signs like the hirsutism, like the acne that's really hard to treat as well. And so, if the goal is managing periods, we can start with that. Some may want to go the non-hormonal route, and I'd be like, we'll give it a chance and see what it does, possibly with a supplement like inositol in that group. But really goals of care, if it's hair, acne, which thankfully hormonal therapy, like with oral contraceptive pills, can be helpful for acne too, in those patients. And there are ways that we can treat the hirsutism as well if other conservative means haven't been as helpful for them.
I mean, I don't think the treatment isn't very different for adolescents and for
a whole
adults,
lot.
right?
Yeah. It's not a whole lot of difference. I've seen some kind of resistance sometimes to starting hormonal therapy.
Right.
So we may start with, lifestyle changes to see if that can be helpful. Because the other thing, and again, we're looking at prevention from another standpoint now, we're starting earlier and trying to see, okay, are you showing signs rather of insulin resistance? With that, you can have darkening around the neck that doesn't go away, looks almost velvety-like. It can be underneath the arms, in the growing area as well. If they're starting to show that insulin resistance, they may be at risk for developing diabetes once they get older.
Loretta, those are signs of insulin resistance?
Yeah,
those are visible signs.
Vanessa, they are so important for people to know. Loretta, will you describe them just a little bit more detail? Because most people who have it don't realize what it is.
You don't think about it. So like common areas on the neck. So you're trying to wash it off and it's like a darker, sometimes it can be velvety coloration and texture in it as well. But yeah, you don't think about it. It's like, dang, why my neck won't get clean? But it could be that they're starting to show signs of insulin resistance there. So the insulin is not working as effectively to put away your sugar, to put away your glucose, which is what we want it to do. And so that can predispose you, or at least, we want to watch out for, I should say, diabetes down the line.
Yeah. Neck, armpit, groin. Those are the three classic spots, Vanessa. And they're really
that's fascinating. I never heard that. Can you, for the lay people, can you explain the difference between hormonal therapy and oral contraceptives?
Sure. One of my faves, because I think that we're kind of programmed to think, okay, oral contraceptives is just for birth control. But there are so many more conditions and diagnoses that oral contraceptives, or even other hormonal options like the pills, the patch, the ring, depot shot, all of those, I just label them as hormonal therapies because they can be used for so many conditions. Just like I talked about with pain for myself, hormones have been great for me because they were able to lighten my period because it was heavy. And now I'm having no cramps at all. If I sense a cramp, I'm like, no.
Not today, cramp.
Not
today.
You will not win today. That's right. So it's so many conditions that they can be used for. And even for the parents now in menopause, hormones are making a comeback there as well.
Oh, our audience is very familiar with the concept of hormonal therapy for them. But I think people
are younger,
think of it only as birth control or sort of like off-label use of birth control. But the way you both are referring to it as hormonal therapy, it's a different marketing, shall we say, or a different lens.
Well, and let's go there for a second, because there are some kids, teenagers, who are looking for both impacts, for both side effects, right? They want to use it for contraception and they want to treat their PCOS or their acne or whatnot. And so we do get a lot of incoming DMs, emails, sort of asking, how, from a parental perspective, asking kind of, how do I handle that? If we're talking about PCOS, but I really think they want it for birth control. And, our answer is always talk about it. But what's your answer?
We really want to focus on the condition that they came in for, the problem that we're looking at, right? So if we came in because we're having painful periods, it could be that now hormonal therapy is an option for you. In that case, it's like, oh, by the way, if you are sexually active, if you are thinking about becoming sexually active, just know that it can be helpful in preventing pregnancy as well, along with helping your period cramps. So I let them know that it's definitely a possibility that it can help with both. We hope it, it will if it's used effectively, right? And then also adding in that little counseling piece that, yes, it's great for these things. It will do nothing to protect you from infection. So please still use condoms.
We're coming back to condoms in a second, but will you share with us, is there a difference between the generic forms of hormonal therapy and the brand name forms?
Got it. So the short answer is no. In terms of the chemically active ingredient, it should be the same for both. Really, the difference, for the most part, between brand and generic medications, regardless of the medications, and even in the case of oral contraceptive pills as well, is it comes down to costs and what insurance may have as a preferred medication versus one that's lower down on the medication coverage. But in terms of how they both act, they should still act the same for you. Now, keep in mind, everybody's different. So some patients may prefer brand name over the generic, but overall they should work the same. So as long as the dosage is the same, the pill may look different, the color may look different, but the packaging, it may all be weird or not what you expected from the month before. But as long as the dosing is still okay, then it should act the same for you.
Yeah. And it's, Vanessa, it's a tricky thing because you'll hear people say all the time, no, in my body, this version didn't work the same. And it's not like wanting to buy the brand label of clothing. That's not really,
right.
It's just, the reality is that sometimes inside their body, one formulation, maybe the carrier, the thing that's not the active drug, but what holds it together in a pill or a liquid, that thing is different. I mean, there are a lot of reasons why medicines can behave differently in different bodies. The goal is that the generic works just as well as the brand, and that the brand works just as well as the generic, right? It can cut both ways.
And what gets in the way? I mean, when I was on the pill, it was, don't smoke because you'll get blood clots if you're on the pill. That's like as much as my 1990s self absorbed from the warnings. What are the warnings that you would now give a young person, Loretta, if they were going on hormonal therapy?
Right. So it definitely would depend on which type of hormone therapy that we're using. So we have some that have the estrogen component in them, like the pills, the patch, the ring. And then we have those that don't have estrogen in them. So any of our estrogen containing options, I definitely want to know, okay, do you have a history of any blood clots, you or personally in the family? For sure. So shout out to your 1990s, because you heard right. For sure. The second is if they're having issues with migraines with something called aura. So they're seeing the spots that come along with or kind of before that migraine hits. We want to know that as well. In those that have borderline blood pressure elevations, that's important for us to know too, because we want to watch it because estrogen can elevate the blood pressure sometimes too. So we're going to monitor it anyway, but if someone's already on the higher end or known blood pressure that's not controlled, something with estrogen in it may not be the first go-to that I would start with. And then, of course, the typical things I want them to look out for in terms of nausea, headaches that they could have, stomach upset. Hopefully those things will go away as they continue to use it. But I definitely want them to know ahead of time if there's any changes in their mood that they are not happy with. I want them to let me know, because in that case, we may need to switch to something else as well.
Yeah. And this speaks to personal health in general, which is something that Vanessa and I speak about a lot now. I don't think we've really thought about it as its own category of topics, but what kids as they're getting older should really know about their own health and wellness so they can carry their sort of medical record verbally to the next provider. And blood pressure is one of those things that most kids have never paid attention to their blood pressure. It's a number that no one tells them. It just gets written down on a piece of paper. And I just want to double down on your comment that it's important to know what your typical blood pressure is. It's a vital sign. It's vital for a reason. And so if you're an adolescent or have an adolescent in your house, teaching them to start getting familiar with those numbers is really important. I'd love to switch to a different numeric topic, the number of sexually transmitted infections
Now dun, dun, dun.
You like that transition? Yeah, it's for you, Vanessa. So for a long time, the data was showing condom use down, STI rates up. There's some recent data that's come out lately. It's a little more reassuring about STI rates, showing that they've leveled off and actually started to come down a little in 2023. What are you seeing? And I want to really connect these dots here. Condom use and sexually transmitted infection rates are inversely proportionate. The more people use condoms, the less likely they are to have an STI, because that's how you prevent them. Also, later sex is associated with lower rates of STIs among teenagers, because if they're not actually having sex, then they don't have risk. But big asterisk, what they call sex and what maybe the researcher is calling sex might be different things. And there's lots of experimentation that kids can do physically that does not involve penetration, like, penile vaginal intercourse that can transmit STIs. So this is like a three-legged stool, right? There's sex, there's condoms, there's STIs. What do you see in your population? What trends are you seeing? And especially around condom use, what are you hearing?
Right. So with STIs, you're exactly right. They are starting to trend down. But in our population that we serve, we know they're still diagnosed more frequently with STIs. So that's why it's so important to have these conversations, to educate them, because all STIs, sexually transmitted infections, may not have symptoms. You may feel just fine, like everything is normal, but you can still have this going on, and that over time can lead to issues in terms of fertility.
Loretta, when you have that conversation with a patient in your office, right? They're not your child, they're your patient, so they're more likely to listen to you. And they say to you, well, I know you tell me I'm supposed to, but I'm having sex with this person and they tell me it doesn't feel good to them, or they don't want to do it if we're going to use condoms because they don't like how condoms, right? Like, how do you address the sort of social emotional aspect that kids are feeling when it comes to this issue?
Right. So I definitely want to meet them where they are, for sure, and let them know the importance of a healthy relationship, because you want to be with somebody that's going to respect your wishes and respect your body and what it is that you want for yourself as well. So be like, I understand where you're coming from, but this may not be the partner for you, because you only know what you're doing. I only know what you're doing in front of me. You know what you're doing with your body, yourself. When your partner leaves you, you don't know what else that they're up to. So that just may not be the person, for you, if they're not willing to use protection to help protect you.
Are they able to hear when you say things like, hey, down the road, STIs can lead to really serious illness, or it's just too far down the road for them?
I think it's too far for it to conceptually make sense to them. So just like with HPV, do you want warts? Do you want genital warts or not? No.
Are you asking me, Loretta, or is that for your patient?
Vanessa knows her answer. She knows her answer.
No!
I mean, what are you seeing? What are you seeing trends away from condom use or towards condom use in the population that you serve in your local area?
Because you're in a college town.
You're in a college town.
Right. So it's hit or miss. It's probably about 50-50.
Yeah.
Most gonna be like, maybe not. We didn't do it every time. We didn't use it every single time, but we do sometimes, and just trying to stress the importance of why every time it's recommended, even if they're on, a highly effective birth control or hormonal therapy method to help protect from pregnancy. We have pregnancy and then we have infections. So we got to cover ourselves for both of them.
But how lucky that they're honest with you, right? Like that number, when you say they're 50-50, what that says to me is half of the kids who you're asking are being very honest and saying, no, I'm not using them. And I think to the parent who's asking the question, if you get a no. Okay, there's a lot of education to do, but at least they're being honest.
Yes. And that goes to speak to the importance of one-on-one time for them to have with their doctor. Because a lot of the times that's where this is coming out. And we're still talking about the importance of confidentiality, what's confidential and what's not. You know, thoughts of you hurting yourself and having a plan or actively, you know, doing things to hurt yourself, those are off the table now. I have to let other people know. Sexual abuse, physical abuse, we have to let somebody know, because at the end of the day, as my patient, your safety is my number one concern right now. It's not about what mama feel about it or anybody else that came with you. It's your safety. And so I feel like once they understand that and we build that trust, they're ready to be as open, as honest as we'll allow them to be. And I love that when we get to that place and you know, you can see them opening up to you about things. It's just really beautiful.
Just to complete the circle, while those things are off the table, you can't, if someone is at risk of hurting themselves or someone else, or is in an abusive relationship, those are things that are reportable, that you must report.
Yes.
But if they choose to tell you that they are sexually active, that is confidential.
It's confidential.
So
that's right.
That is as important for the kids to know what secrets you keep. And when you are seeing kids over 18, right, there is full confidentiality for all of that, to the point where even if the parent calls you and bugs you and wants to know legally, can you speak to that for a second?
Yeah, we're not obligated anymore. Once it's over 18, they are considered full-fledged adults in the medical world. They can make their own decisions. Let's say if parents were unsure, hesitant about, say, Gardasil, certain vaccines, now at 18, they can decide, you know what, I want that. And we can provide it to them because they are able to make that decision and consent for their own care at that time.
So, Loretta, let's talk about vaccinations. That's a big conversation out in the world these days, post-election. It's, post-COVID. And we know there's tons of data about Gardasil, the HPV vaccine, and how it can protect against some forms of HPV. But some people are concerned about it or uncomfortable with it, and they don't have their kids vaccinated. What percentage would you say of young people over 18, are you seeing a lot of folks come in at that point and say, okay, I didn't get it when I was a kid, I'd like it now? Like, what are you seeing in your practice?
Right. So when they're coming in, I still like to check their vaccination record, because with HPV, it's not anything that's required. It's nothing that they have to have, like your tetanus shot,
right,
or your meningitis shot. And so that's kind of how it can slip through the cracks, actually, where they aren't covered, or they may have had a conversation years ago about it. But if parents didn't want it, it's like, I guess, we won't worry about it. But if you keep bringing it up, just like keep bringing up that flu shot, one day they may be like, okay, we'll go ahead and get it. Or just hearing it that other time, it hits differently, it clicks differently for them. And then we can start the series for them at that time.
Do you find that you get kids coming in saying, I have a friend who was just diagnosed with HPV, who now has to be treated for their HPV, and now I'm thinking I might want that shot?
I'm nervous, right? I'm scared. So is there a way that I can get protected too? Absolutely. Of course, the earlier you get it, preferably before you're exposed to HPV, the better. But like you all alluded to, there are so many strands of HPV and strands that are covered that you still can have that protection, even if you start later than, say, 15 or something like that. You can still get the protection from Gardasil vaccine.
Loretta, we're recording this episode after the 2024 presidential election, and we are all braced for some changes in the laws around women's health and women's reproductive health. And I'm curious, you live in the state of Georgia, which has had, as you said before we started recording, it's like whiplash around some of the laws. Yeah. Can you speak to what you're thinking about and what your goals are in a state where there are real restrictions in place around women's reproductive health?
I'm encouraged and empowered, really. And it really pushes my why for what I do. I knew it was already important that we make sure that we have trusted resources and we focus on our teens and tweens and our young adults during this crucial transition time. But now it's even more important that we do so because literally, like the saying goes, an ounce of prevention is worth a pound of cure. And in this case, as well with women's health, with reproductive rights, I want to be able to tell you so many options that you have. I want you to be educated on all the things and help you make the best choice for you so we don't have to rely on the laws on the other side that may not always be in our best interest. We're being so proactive now that we can hopefully, as best we can, avoid even some of those consequences that really just won't be in the best interest for your health overall. And so if we can start on the front end, educate on the front end, really create that safe space for these sensitive conversations to happen, really, I feel that's where the biggest change will be made.
Can I ask you, what are the sex ed requirements in the state of Georgia today?
I chuckle because there are none. It's still abstinence only primarily. There is no comprehensive sex ed. So it begs the question, where are they getting their information?
Right.
If it's not from home,
right.
If it's not from home, if they're not comfortable or it's only a certain way and it's not expansive to include all things, to include pregnancy prevention, include infection prevention. If it's with their peers, okay, they're all coming through together. No one knows for sure, right? Or if they're depending on social media. And that's why I feel that it's important that I'm on social media as well, because I want to meet them where they are to be an informative, hopefully educational and entertainment rather source that they can get the right information from. So, really trying to be a helpful source in those cases, especially here in Georgia, for rural Georgia as well. To show that there's a different way that we can do this and you can be healthy and you can be happy. You can enjoy your relationships as well, understanding what consent means and what it doesn't mean and making the best choices for you. That's what it's about.
And understanding what body parts do and how biology and physiology work and things that are not values-based at all. They're just facts, and sharing those facts in a totally non-judgmental way is a really incredible way to get the information out there.
And naming those body parts. Let's not be ashamed to name them. We don't come up with different name for your ears and your eyes. It should be the same way for the vulva, for the vagina. Tell me exactly what you're talking about anatomically. Yep.
Well, Loretta, if we can ever help you do some work down in Georgia in getting people some good science-based information, I have no problem saying the word vagina in front of hundreds and hundreds of people.
You do it every day.
Speaking my language. I love it.
I'm often in auditoriums with audiences and I'm like, this is probably the first time the word erection has ever been uttered in this auditorium, aloud with a microphone. Yes. But if we can ever be helpful in getting that wonderful ounce of preventative medicine with information and support to the folks in your community, we are so happy to do that. You are a ray of absolute optimism. I mean, Carr is a very optimistic person, but you blow her optimism out.
I look like Debbie Downer.
I know.
By comparison.
She looks like Eeyore compared to your piglet, because you are just so optimistic, and in a moment when we don't know what's next and we don't know how the laws are going to change, it's wonderful to have your voice as part of this work, being positive and hopeful and empowering for all the young people out there. So thank you for what you do. And thank you for sharing your story. Also, it's so powerful to hear that it's as much personal as it is professional for you.
Absolutely. Absolutely. You're so welcome. I love doing it. And like you said, it comes off. And once I figured out this was, my jam, this was my calling, it's been no stopping me. So getting loud with it and getting louder, staying optimistic, that's really what's important.
Well, we hope you'll come back and visit us.
And we'll share all the ways that people can find you in the show notes.
Yes.
I know they will want to find you and follow, and your patients and your community. Oh, they're so lucky.
I was going to say, maybe I should get on a plane with my daughter and come see you.
Sure. Yes. Come visit. We'll show you the town.
That's really cost effective, right? That makes a lot of sense. So anyone in Georgia who's listening, you are within driving distance of Loretta, of Dr. Duggan. So
yes,
something if I'm willing to get on a plane, then you can get in your car.
That's right.
Come back and see us, and keep spreading your light in the world. Thank you for being on with us.
Absolutely. Thank you all so much for having me. It's been great.
Thank you so much for listening. You can email us with questions, feedback, or episode requests at podcast@lessawkward.com.
If you want to learn more about what we do to make this whole stage of life less awkward for everyone involved, our parent membership, our school health ed curriculum, our keynote talks, and more are all at lessawkward.com.
And if you want products that make puberty so much more comfortable, visit myumla.com.